webinar of Dr. Tushar Shah. Every month we are having one good scientific session by Dr. Tushar Shah, and he is giving very good feast of knowledge to us, and it helps us in our practice. I welcome Dr. Preeti Madam to introduce our speaker as well as the topic.
Thank you, Dr. Sanjay. On behalf of the President, Dr. Pragnesh Shah, and office bearers of FFPAI, I welcome you all. A warm welcome to you all during the festive season with Ganesha and Dasara and Diwali coming in. And rightly, we have another eminent star with us today, which is Dr. Tushar Shah from Mumbai. And today he doesn't need any introduction, but still for any newcomers, he is a physician, renowned, eminent physician from Mumbai, Advanced Multi-Speciality Hospital. And he is an ardent teacher. His passion is teaching, and teaching. And rightfully so, he is going to be with us this weekend to teach the Bangaloreans personally also. Thank you, sir, for accepting the invitation. And today's topic is very relevant to all family physicians with drug-drug interactions. We use numerous drugs, but we do not know when we combine the drugs, what are the effects and what is going to happen. So he is going to enlighten us today on drug-drug interactions. Over to Dr. Tushar Shah. Rahul, please play the PPT.
Thank you, Dr. Preeti. Thank you, Rushil, for organizing the PPT. Can you expand it? Thank you. So this is today, of course, drug interactions, or I have shortened it to drug interactions. There are, of course, drug-food interactions also, which I will not be talking about. I will concentrate on interactions of oral drugs and on interactions that we may commonly find in our OPD, and therefore which are relevant to the general physician. Let's begin the Rahul, if you can give me the next slide, please. Yeah. Next, please. Yeah. So this is how the format is. I'll talk about one drug interaction, and then what do we do to circumvent this interaction? How do we bypass this interaction or protect the patient against this interaction? So we have about 15 or 20 interactions. So the first one is this. Allopurinol or febuxostat, if given in a patient on pyrazinamide, can raise the blood levels of pyrazinamide, as the latter is metabolized by xanthine oxidase. Therefore, in effect, pyrazinamide-related hyperuricemia, if treated with allopurinol or febuxostat, can worsen pyrazinamide toxicity, especially hepatotoxicity. So one important thing to learn, something that I have said before also, is that pyrazinamide-related hyperuricemia does not respond to colchicine in the acute pain, nor is it useful to use urate lowering therapies in pyrazinamide-induced hyperuricemia. In fact, you will worsen the status of the patient. Now, this means that next slide, please, Rushi. Yeah. So our action, therefore, is do not treat it with xanthine oxidase inhibitors. You may cause hepatotoxicity of pyrazinamide. Next slide, please. The person who's controlling the slides can refer to you when changing the slide. Okay, so next drug interaction. Co-administration of an NSAID, particularly non-specific NSAID, and a corticosteroid increases the incidence of GI bleed. Now, this is obvious. So when will this happen? often we will be having a patient, say, of ankylosing spondylitis, who's taking NSAIDs for a long time, for example, a corticosteroid, then GI bleed increases. And how do we circumvention is one, you must start a PPI. Now, the commonest situation when this will occur is a patient is on a cardioprotective low dose aspirin, and therefore the patient is already on an NSAID. And if you now add a corticosteroid, you will have to start a PPI in all such patients. On the other hand, if the patient is requiring a corticosteroid and requires an NSAID also, then you may use a less GI toxic NSAID like itodolac, because that is a partial COX-2 selective drug and will not cause a significant GI irritation. Of course, even in such patients, you will give a PPI. Remember that the purely selective inhibitors like etoricoxib, I do not like because they have significant cardiovascular toxicity. So COX-2 inhibitors should be partially selective like etodolac. Next slide, please. Another drug interaction, very common. If we often give drugs like Rosavel F or Razel F, etc., co-administration of a statin and a fenofibrate increase the chances of myopathy. We circumvent this problem by not co-administering them in most cases. Most cases do not require both a statin and a fenofibrate. Fenofibrate is one of the most overused cardiac drugs or misused cardiac drugs. Even a triglyceride level of 295, 300 will persuade us to start fenofibrate incorrectly. May I have the next slide, please? Sanjay bhai, who's managing the slides? You are mute. If you can just give me the name of the person, I will just wake him up intermittently.
He's Rahul.
Rahul, can you hear me? Rahul? Can we wake him up?
Yes,
so you're not changing slides when I tell you to. Why is that?
Sorry, sir. Sorry.
Be alert, huh?
Yeah. Pay attention to this only. Otherwise, give me the control of the PPT, whichever is convenient to. Yeah.
Sorry.
Okay. So, can we have the previous slide, please?
Okay.
Yeah, thank you. So our action, when we want to give fenofibrate and statin, we have to evaluate the indication of each. This combination is unindicated in most patients who receive it. Mostly the fenofibrate component is completely unnecessary. So do not give this combination in most situations. And if you do give the combination, please ask the patient to report muscle pain. And if muscle pain is reported, immediately stop the drugs and do a CPK total. Next slide, please. Drug interaction number 5. Diuretics and NSAIDs can reduce renal elimination of lithium and lead to lithium neurotoxicity. Now, this is something that you may not see commonly, but there are many patients of bipolar illness who are on lithium, and they may have a comorbidity which makes us give them diuretics like hydrochlorothiazide. Any diuretic or any NSAID given to a patient with lithium can increase lithium levels. And how will you recognize this lithium toxicity? Most commonly by a new tremor developing in the patient. May we have the next slide, please? So when you have this situation where you have to give NSAIDs or diuretics, not steroids, but there is a mistake here, NSAIDs or diuretics, you have to reduce the lithium dose by half when you co-prescribe. So just that for that duration of NSAID therapy. Next slide, please. Yeah. Respiratory quinolones and macrolides can both individually cause QT prolongation, and given together, they can be fatal. I can't imagine how many deaths must be occurring due to QT prolongation related to drugs. Tens of thousands of deaths per year are recorded in Western countries. Now, moxifloxacin is commonly used as a respiratory quinolone, in, say, atypical pneumonia. Clarithromycin is indicated in atypical pneumonia. If we become brave and give both drugs together, we can kill the patient by a ventricular arrhythmia. So you cannot do that. Maybe the next slide, please. They are both useful in atypical pneumonia. Don't co-administer. But if you have to give two drugs in a pneumonia which is atypical, what do? One, you can use either one of the two, a macrolide and a resveratrol, and add doxycycline, which is also an atypical pneumonia drug, or cotrimoxazole, which is also an atypical pneumonia drug. So definitely do not use both together. Having said that, between azithromycin and clarithromycin, azithromycin has a lesser QT prolongation than clarithromycin, so maybe little safer. So I have given up on clarithromycin in most situations. We will come to that again. Next slide, please. Rifampicin. Rifampicin reduces blood levels of oral contraceptives. Now, this is one of the most famous drug interactions, and everybody knows about it. Rifampicin renders the oral contraceptives ineffective, and therefore they don't prevent pregnancy. So a patient on AKT may suddenly become pregnant if you have not asked them beforehand whether they are on OC pills. Why does rifampicin do this? Rifampicin is a CYP inducer, meaning it induces hepatic enzymes that metabolize oral contraceptives. So we have to not give oral contraceptives in such patients. What do we do? Next slide, please. All young females, if they are desirous of pregnancy and are being given AKT, are desirous of not becoming pregnant and given AKT, they must switch to barrier contraceptives. You must tell their husbands to use barriers, or maybe the female can use the barrier contraceptive, but that is a must. Rifampicin is one drug which has the largest number of drug interactions known to us. It is an inducer of several CYP enzymes, and therefore it reduces blood levels of OC pills and other drugs like warfarin, digoxin, etc. So every rifampicin patient, you must look up an app which shows you drug interactions before giving drugs. Next slide, please. This is another drug interaction that I have seen so commonly, especially at the hands of urologists. Ciprofloxacin causes increased blood levels of alfuzosin. Ciprofloxacin is a CYP3A4 inhibitor, meaning it inhibits the enzyme that metabolizes alfuzosin. Therefore, the alfuzosin levels increase. Now, when will this combination be used? Typically, if a patient comes with prostatitis, quinolones are considered the drugs of choice for prostatitis. These patients may be on alpha blocker for BPH, like alfuzosin, and ciprofloxacin and alfuzosin together will increase blood levels of alfuzosin. Alfuzosin, being an alpha blocker, can cause significant postural hypotension, and patients can have falls. May we have the next slide, please? Amongst the three prostate-specific alpha blockers, tamsulosin, silodosin, alfuzosin has the most drug interactions, as it is the only one metabolized by CYP enzymes. We must dump alfuzosin in the garbage bin. Alfuzosin should not be used in any situation, whatever the advantage being promoted by the pharma company, that it has less retrograde ejaculation or less postural hypotension. I do not believe alfuzosin should be existing at all. Just to tell you this, what is CYP? I've been using the word CYP frequently. Cytochrome P450 enzyme systems are enzyme systems predominantly in the liver, also in other places, but predominantly in the liver. What do these enzymes do? These enzymes metabolize the medicines that we take, besides metabolizing other foreign substances. They can either convert a prodrug into an active drug, or metabolize an active drug to make it inactive. Not all drugs are channeled through CYP enzymes. About 50 to 60% of drugs that we take are excreted through the CYP enzyme system. Therefore, if you give drugs that stimulate the CYP enzyme system, then you might cause degradation of the drugs which are substrates of that enzyme. So the most important CYP enzyme is called CYP3A4, which is the mother of all CYP enzymes. Now, this enzyme, okay, CYP3A4 is a fantastic molecule, one of the most wondrous molecules in the body, which metabolizes about 50% of the drugs which we take as medicines. And therefore, uh, drugs that stimulate CYP3A4 or inhibit CYP3A4 become very important sources of drug interactions. Maybe the next slide, please, Rahul. Okay, another drug interaction coming up. Amiodarone is a CYP3A4 inhibitor and hence can significantly raise blood levels of atorvastatin and warfarin. Amiodarone, like many other, I will come to all the inhibitors of CYP3A4. Now, imagine this: a patient is a patient of atrial fibrillation, and the patient therefore is on warfarin because maybe it's a valvular atrial fibrillation. Often, a patient with atrial fibrillation will be on amiodarone. If amiodarone and warfarin are being given together, then warfarin levels can increase and therefore bleeding can occur. Atorvastatin is another cardiac drug that may be given sometimes with amiodarone, and atorvastatin blood levels increase due to amiodarone, and atorvastatin related myopathy will increase. Next slide, please. Thank you. My face is not seen, meaning I'm a little क्या बोलते हैं, narcissistic tendency wala admi. So if my face can be seen somehow, because my video is on, Rahul. Okay. In a
You are
patient on
visible, sir.
I'm visible, okay, except to
Yes.
myself, which is fine, sir. In a patient of polypharmacy, one should be wary of using atorvastatin and should routinely replace it with rosuvastatin. Atorvastatin has CYP3A4 related drug interactions. Rosuvastatin is not metabolized by CYP enzymes. 90% of rosuvastatin is excreted unchanged. Therefore, I personally have stopped using atorvastatin completely, except maybe when nephrologists want to use it in CKD, where they say that atorvastatin may be safer in CKD than rosuvastatin. Except that one situation, I do not use atorvastatin at all, especially now that the costs are not very different. So rosuvastatin does not have drug interactions. Atorvastatin has multiple drug interactions. Here we come to the CYP3A4 enzyme inhibitors. Which are the various inhibitors of CYP3A4? Just remember this, that all these inhibitors will increase the blood levels of, say, atorvastatin, for example. And there are many other drugs whose levels will increase. The inhibitors that you should remember are clarithromycin, itraconazole, ciprofloxacin, diltiazem, verapamil, and amiodarone. These are the most important inhibitors of CYP3A4. Incidentally, grapefruit juice is a strong inhibitor, and now in the market, we have started getting grapefruit juice. So in a patient on polypharmacy, please tell them grape juice is different, grapefruit juice is different, as you know. So grapefruit juice should not be had by any person who is on polypharmacy. Polypharmacy, when I say, I mean 5 or more drugs that are not vitamins or supplements. Next slide, please. Yeah, this is another important drug interaction because of greater use of psychiatric drugs happening currently. 3 drugs, bupropion, fluoxetine, and paroxetine, all antidepressants, all increase blood levels of metoprolol. I've just taken this one example. There are many examples of these drug interactions, but metoprolol levels will be increased. This increases the risk of hypotension and bradycardia. There is another CYP enzyme called CYP2D6, which is extremely important in psychiatry. CYP2D6 is inhibited by BFP and bupropion, fluoxetine, paroxetine, and metoprolol is exclusively inactivated by CYP2D6. Therefore, if bupropion is given, metoprolol levels will rise. Next slide, please. So what is our action? Our action is this. In a patient who's already on SSRIs like fluoxetine and paroxetine, and the patient has to be given a beta blocker, don't choose metoprolol. Choose nebivolol or bisoprolol, which are not significantly metabolized by CYP enzyme systems. What is the other option that we have? Next slide, please. Sorry, I will go back to the previous slide, please. Now, if you have to give metoprolol, meaning you don't want to give any other beta blocker, then instead of fluoxetine and paroxetine as the SSRI, use S-citalopram as the SSRI, because S-citalopram does not inhibit the CYP2D6 enzyme. Next slide, please. Higher doses of amitriptyline are in use. Now, imagine this. How commonly will this be happening where a patient is on fluoxetine and on amitriptyline? Not very uncommon, not very rare. Two antidepressant drugs are often given together. And if you give these two drugs, especially a higher dose of amitriptyline, what will happen is that the amitriptyline levels will increase, which will increase the chance of hypotension, postural hypotension, increase the chance of deadly arrhythmias. So, and of course, constipation. But this can be a killing combination. So be wary of this. Next slide, please. So again, what did I say before was that if you do wish to use an SSRI along with an amitriptyline, prefer escitalopram or even sertraline, which does not have such an inhibiting effect on CYP2D6. Next slide, please. Rahul?
Slide is changed, sir.
Yes.
Rahul,
Sir, your network is low.
next slide, please.
Slide is
Oh,
changed.
okay. So I'm so sorry. Okay, now I get the next slide. I will try to see if I can get my network to become better. While quinolones by themselves cause dysglycemia, administration in patients on OHAs like sulfonylureas can lead to severe hypoglycemia. Oral hypoglycemic agents, not metformin, which is not such a hypoglycemic agent. Oral hypoglycemic agents like sulfonylureas or insulin, if a patient is on these, and if you give them fluoroquinolones like ciprofloxacin, levofloxacin, then they can get hypoglycemia. We use the word dysglycemia because occasionally quinolones will also cause hyperglycemia. So be very, very wary of giving quinolones in a patient on oral hypoglycemics. Next slide, please. This is one reason why we have to reduce our prescriptions of quinolones. But this is not the only reason. There are so many reasons that our use of quinolones should come down to maybe 5% of what it currently is. Why? I'll just give you a couple of things. Quinolones have been used in UTI. We know that UTI E. coli are completely resistant to quinolones. Gastroenteritis due to E. coli usually does not require antibiotics, but even if it does, quinolones won't act. Typhoid or paratyphoid, quinolones don't act anymore. Respiratory quinolones are, yes, useful, but now they have been kind of delegated to tuberculosis treatment. So we should not use even the respiratory quinolones for LRTI. So most quinolone prescriptions are currently incorrect. We should stop using, and especially we should stop using the combinations of ofloxacin, ornidazole, etc. Because ofloxacin does not work. One condition where quinolones still work, but otherwise quinolones are fairly useless. May we have the next slide, please? Pioglitazone and NSAIDs given together can increase the risk of heart failure and fluid retention in predisposed patients. Suppose a patient is a patient of ischemic cardiomyopathy, ejection fraction 40%, and the patient is given this combination. Unfortunately, as a diabetic patient, we would normally not give pioglitazone in a patient with low ejection fraction. But if you give both together, individually themselves, they will cause a problem. But both together can be disastrous failure. You must remember, even though if I say this again and again, I want to say it again. The NSAID that causes most heart failure is etoricoxib. Etoricoxib deserves the garbage bin. So etoricoxib and pioglitazone, definitely a bad combination. But even other NSAIDs with pioglitazone in a patient with already a compromised heart will cause heart failure. Next slide, please. Next slide, please. If you must give an NSAID to a patient on pioglitazone, must give, yeah, even if the patient is normal heart and you want to give an NSAID with pioglitazone, choose naproxen, because that has the minimum cardiovascular toxicity amongst NSAIDs, and that also used for minimum duration, not more than 5 days definitely. Next slide, please. It is not unusual for a cardiac patient to receive both low dose aspirin and a thiazide or any other diuretic. Now imagine this, all cardiac patients with atherosclerotic cardiovascular disease will be on aspirin, maybe almost all, and diuretics like combination with sartan or alone or furosemide will be there. This combination can cause significant hyperuricemia. As you know, high dose aspirin, which we don't use, causes hypouricemia, and low dose aspirin causes hyperuricemia. Now, this, of course, can precipitate gout. What do we do about this? Next slide, please. If significant hyperuricemia does occur, especially if it is symptomatic hyperuricemia on this combination of aspirin with diuretic, and if the diuretic is mandatory, one will need to switch from aspirin to clopidogrel. As you know, there is a current spate of evidences which say that if you are using a single antiplatelet, maybe clopidogrel is better than aspirin. So anyway, in this situation especially, you will switch from aspirin to clopidogrel. Next slide, please. Paracetamol. We don't usually associate paracetamol with drug interactions, but it has one drug interaction that I know about. There might be more, but I know about this one. It can cause blood levels of warfarin to increase, causing bleeding. This does not occur through CYP, but uh, this is an unusual combination. So if a patient is on warfarin, you can't give full dose paracetamol. Next slide, please. So if you do want to give a patient on warfarin paracetamol, limit yourself to 2000 milligram per day, because this is a dose related drug interaction. Our normal limit is 3000 or even 4000 milligram per day of paracetamol. But in patients on warfarin or other coumadin derivatives, acetrom, etc., you should not exceed 2000 milligrams. Next slide, please. Yeah, the GI absorption of quinolones is reduced by calcium, iron, and liquid antacids. So first of all, I said we should not use quinolones as much as possible, but there are some indications of using quinolones, for example, prostatitis, shigellosis, and now in some cases H. pylori. If you do use quinolones, then do not, you must remember that their absorption is reduced by calcium, iron, and liquid antacids. So what do we do? Next slide, please. Our action is that we have to give quinolones 4 hours away from iron, calcium, and liquid antacids. Next slide, please. Patients of heart failure, especially HFrEF, meaning heart failure with reduced ejection fraction, what we used to call systolic heart failure. These patients often receive both ARNI and spironolactone. ARNI means sacubitril plus valsartan combination, and aldosterone antagonist like spironolactone or eplerenone. This combination can cause hyperkalemia. This is well known. Next slide, please. So what do we do about this? Because this combination has to be given. There are 4 drugs that are pillars of HFrEF. Next slide, please. I'll just check my connection again. Next slide, please. Rahul, are we on the next slide? No, sorry, previous slide, please. I'm so sorry. Yeah. So ARNI and aldosterone antagonists are the 2 of the 4 pillars of HFrEF therapy. The other 2 pillars are beta blockers and SGLT2 inhibitors. What do? We have to give both, and therefore we have to monitor serum potassium. That's all we can do. So keep a watch for hyperkalemia in such patients. Next slide, please. Okay, so now this is the most heavy slide, or there is a lot of on this slide, but this slide, if you can take a screenshot or a photograph, this is a slide that can save lives. A person who's prescribed itraconazole or clarithromycin may have so many drug interactions. These 2 drugs, itraconazole and clarithromycin, inhibit the most important CYP enzyme. That CYP enzyme is called CYP3A4. This CYP3A4 metabolizes or reduces the levels of uh, the enzyme and therefore increases the levels of some drugs. The drugs that levels whose levels are increased include amlodipine, atorvastatin, simvastatin, warfarin, apixaban, rivaroxaban, alprazolam, diazepam, alfuzosin, eplerenone, ranolazine, ivabradine. Now imagine you can have deaths with almost all of these. If amlodipine causes hypotension, you can have a fall. Similarly, with alfuzosin, you can have a fall. Hyperkalemia can kill if eplerenone is given with sclerothromycin. QT prolongation occurs with ranolazine and clarithromycin and itraconazole and bradycardia with ivabradine. So many potentially killer drug interactions with itraconazole and clarithromycin. So what do? I rarely prescribe clarithromycin. When is clarithromycin typically prescribed? In LRTI, sometimes it is prescribed to cover atypicals. Now, this concept of wanting to cover typicals and atypicals at the same time is a peculiar concept, especially with specialists. So I think if you can be confident on the clinical picture or on the radiology imaging, that is, that this is typical, then please stick to typical antibiotics. And if you think it is atypical, give maybe azithromycin in a patient on polypharmacy. In a patient on polypharmacy, you cannot give clarithromycin because you will not know what drug interactions are possible. Similarly, with itraconazole, when you give itraconazole in patient on polypharmacy, you have to first check the drug interaction app and find out if you are giving something which is going to be toxic. Do remember these are dose related. So if the patient is on amlodipine 2.5 and if the BP is 140/90, maybe there won't be a problem. But if the patient is on 40 milligram atorvastatin and you give an itraconazole, uh, this might be disastrous to the patient and cause myopathy. So we have to take care of these 2 drugs, especially itraconazole and clarithromycin. Next slide, please. Warfarin. Warfarin is another drug that we know has several food drug interactions and several drug interactions. Again, this is a busy slide, and I don't like busy slides, but this is again something that you can save as a screenshot and maybe read it sometimes. Warfarin is metabolized by 3 different CYP enzymes. Inhibitors of all these enzymes can cause increased blood levels of warfarin. So CYP2C9 inhibitors can cause this do we have to take corrective action?
Sir, you are not audible.
So you are frozen.
Hello.
Network has gone.
So now what happens, sir?
So,
I think Dr. Tushar Shah's network has gone.
Yeah, we can't do anything at our end.
Yes, yes.
Okay.
Right from the beginning, his network was not
Yeah.
proper.
Yes, yes, sir. Yes, sir. So many troubles in their videos.
If anyone has his number, please contact him.
I'm calling him. I'm calling him.
Yeah, okay.
Okay, ma'am. Okay.
Sir, your sir's network not working. He's frozen. Can you inform him?
Yeah, we can see him
Okay,
now.
okay.
We
I
can
call
see
him.
him now.
Okay, I'm so sorry for this. Yeah. So we were talking about how warfarin is metabolized by 3 different CYPs. Now it is not easy to remember all the drug interactions of warfarin. May we have the next slide, please? So there are 3 enzyme systems which metabolize warfarin. So each enzyme system has different drugs which inhibit the enzyme, and therefore warfarin levels can increase with uh, multiple enzyme inhibitors. So what do we do? How do we remember this? Is what my next slide is about. Next slide, please. Okay, so I request you, whenever you have a problem and regarding drug interactions, especially when you're using drug like itraconazole, clarithromycin, warfarin, which have several drug interactions, go on. There are multiple apps available, right? There is a Medscape a drug interaction app, which I think is useless. There is there are multiple apps available, but if you want a specific answer, go on Perplexity AI. Perplexity AI is an artificial intelligence app, which is an app also and a website also. Perplexity AI, you can see the small letters on the top second line. Just go on Perplexity AI, download the app if you like, or go on the web page and ask the drug interaction. Just ask if you want to give. Here I have asked ranolazine and itraconazole. What is the drug interaction? Ranolazine, as you know, is an angina drug. Itraconazole is a fungal medication. I have asked it what are the drug interactions related to this, and it has given me a correct answer, a very good answer. And because though both these drugs cause QT prolongation and can cause sudden death if this combination is used. Now, it not only gives the answer, it gives references to the answer. It will tell you the 4 or 5 references from where it has chosen the answer. So it's a different kind of search engine, Perplexity. It does not just give you the sites to go to. From those sites, it will cull or select an appropriate answer and then give the references to the sites from where it got the answer. So instead of a search engine, it is called an answering engine. This answering engine is, I think, a brilliant AI tool that you have. And please use it, especially in drug interactions where it can get very, very confusing as to what to do. Yeah, I think that's the end of our PPT. Is that right, Rahul?
Rahul, next slide.
No, I think we have ended. Rahul,
Yeah.
thank you so much. Sorry that my net was not good. Yeah, over to you, Dr. Preeti.
So thank you so much for so many interactions and you have given, and thank you for your vast knowledge of all the drugs. And we get confused even with the drugs, and you know all the interactions also. That's very nice. On the chat, there is one question.
which says, could you please give the list of the major CYP inhibitors once again?
Yeah. So remember antifungals. Amongst antifungals, itraconazole and ketoconazole. We know that ketoconazole is no more used orally. So amongst antifungals, itraconazole. Amongst antibiotics, clarithromycin, less so azithromycin, important clarithromycin, and quinolones, especially ciprofloxacin, is a CYP3A4 inhibitor. Amongst cardiac drugs, verapamil and diltiazem, the two brothers, they are CYP3A4 inhibitors. Grapefruit juice is a CYP3A4 inhibitor. Uh, so we have covered antifungal, antibiotic, anti-hypertensive, and yeah, I think these are the drugs that are. There must be one or two more which I'm missing, but yeah, these are the drugs that inhibit 3A4, which is the most important enzyme system. And 3A4 is stimulated by griseofulvin and rifampicin. These are the two important inducers. One more is ritonavir. Yeah. Somebody gave a good drug interaction saying that uh, doxycycline and isotretinoin together can cause benign intracranial hypertension, which is a good interaction, especially because both drugs are used in acne, and you should not use that combination.
So Dr. Sanjay is asking, which combination of diuretics can be given together?
I suppose you are asking two diuretics if they have been to be given.
Yeah, two diuretics. Yes.
Then
yes,
obviously one diuretic would be a potassium sparing diuretic, and one will be a potassium losing diuretic. For example, you will use furosemide, which causes hypokalemia with spironolactone. So yeah, I would use these two as a standard combination. And there are no combinations available of, say, a thiazide with a loop diuretic. So there is no such combination available, and you should not be using hydrochlorothiazide and furosemide in the same patient.
No, in a certain patients are on antihypertensive having hydrochlorothiazide. And if they develop edema, then they are given like diuretic like this ditor or torsemide or furosemide. So hydrochlorothiazide and torsemide are okay.
No, absolutely not. They will cause significant hyponatremia and hypokalemia, both hyperuricemia. All three side effects will be significant. So they are not okay. So if you have to give furosemide to a patient, you will have to remove the hydrochlorothiazide because it is a redundancy. So furosemide will do the work of hydrochlorothiazide. Having said that, one thing that we should stop doing is using symptomatic treatment of edema. Many patients are given edema medicines because they are swelling in the legs. Now, what happens is actually what happens with oxymetazoline and xylometazoline. When we continuously give oxymetazoline for nasal congestion multiple days, you get a rebound rhinitis, which is called rhinitis medicamentosa. Similarly, if you overuse diuretics when there is no indication really, there is no cardiac compromise, there is no renal compromise, and you are giving it for cosmetic or symptomatic reasons, this diuresis itself decreases intravascular volume, which reduces renal perfusion, which in turn causes renin-angiotensin release, and this in turn causes aldosterone secretion from the adrenals, which causes salt and water retention. So again, giving diuretics can worsen salt and water retention by way of renin-angiotensin stimulation. So you have to not give cosmetic diuretic therapy.
Sir, does prokinetic drugs have any major interactions?
So they have major side effects. As you know, levosulpiride causes Parkinson's disease or Parkinson-like disease. So the side effects are significant. The neurological side effects are significant. Drug interactions, I'm trying to think. There used to be a prokinetic which caused QT prolongation, but it is banned now. I will not remember the name quickly. Otherwise, I don't know of drug interactions with other drugs.
So can azithromycin And anti-allergics being given together?
Oh, yes.
Azithromycin with anti-allergics.
Yeah, I suppose you mean azithromycin with Allegra or meaning
Yeah,
dexamethasone,
Allegra.
etc. So what the question is being asked, because azithromycin causes QT prolongation, and terfenadine, which is the precursor of fexofenadine, used to cause QT prolongation. I think the fexofenadine is much safer. So you can use bilastine, fexofenadine, cetirizine, etc. in combination with azithromycin. Yes.
Dr. Sanjay, you were asking.
One of my patient has taken AC inhibitor and ARB both together for 1 year. I have seen prescription of one doctor and
Yeah.
he developed nothing.
So there used to be a concept of complete RAS blockade. That used to be a concept maybe a decade or 2 decades ago, where you give both together so that you have completely inhibited the renin-angiotensin system. That was a fad. That was a transient wave of prescriptions of that combination, and that must have persisted in some way. But of course, we know that it's like giving metoprolol and atenolol together. We should not give that.
So one Dr. Desai is just asking amiodarone, nothing to the question.
So amiodarone has
Is
many
the-
drug interactions, and he has prompted me to tell me that amiodarone is also a CYP3A4 inhibitor. Thank you, sir.
Okay.
So one of the drugs that I missed was amiodarone.
So macrolides with theophylline, can they be used?
No. Macrolide and theophylline is another good common in problem. Macrolides increase blood levels of theophylline, and therefore theophylline toxicity can increase. Similarly, surprisingly, ranitidine increases the blood levels of theophylline, and we should not use this combination also. Smokers and theophylline. Chronic heavy smokers have reduced levels of theophylline through the CYP enzyme systems, and therefore chronic heavy smokers require a higher dose of theophylline than non-smokers.
PPI, those who are taking PPI, any PPI, are there any restriction of any other medicines?
So PPIs cause B12 deficiency. Metformin causes I'm just thinking aloud. Metformin causes B12 deficiency. So PPI given with metformin may cause a problem. PPIs increase fracture risk by decreasing calcium absorption. Pioglitazone increases calcium fracture risk. So pioglitazone with a PPI may have an additive increase in fracture risk. PPIs increase gut infections, and antibiotics given with PPI will further increase gut infections like C. difficile. That seems to be one possible additive, not an exact drug interaction, but an additive side effect. That is what I can think of.
Thyroid medicine and PPI.
One thing that I forgot. Omeprazole, very interesting PPI is omeprazole. Omeprazole through the CYP system is metabolized through the CYP system, and omeprazole exhibits different metabolisms in different individuals. So, for example, between Sanjay bhai, you and me, omeprazole may have different blood levels because our CYP behave differently. This is called genetic polymorphism. So, in some people, omeprazole acts 50% better than in some other people. So so that is one problem with PPIs with omeprazole. And secondly, there is of course a popular drug interaction that omeprazole reduces the effectivity of clopidogrel because it does not allow the prodrug clopidogrel to be converted into its active drug. So there has been both sides evidence that so, but if a patient is on clopidogrel, I would not give omeprazole as the PPI. Sir, you were asking about one more.
How much time interval between thyroid medication and PPI?
So I would say 1 hour is good enough. So semaglutide, so
1 hour.
the unfortunate part will be if a patient is on semaglutide, thyroxine, and a PPI. And now what do we do? So semaglutide first, thyroxine next, and the PPI third would be the sequence of drugs given.
Sir, Dr. Desai is saying it's a very great revision. Even I would like to second it and say it's a big revision for all of us. Going through pharmacology, and
Yeah.
you rattled off like the pharmacology textbook.
Yes.
Thank you. I have to thank Dr. N.K. Kumar, who has been brilliant. Of course, he works on the study table, and I am the face here. But Kumar has been helping me throughout all lectures that we do. So thank you, Kumar.
Yes.
After your lecture on dengue, I think we Ahmedabad doctors have improved our practice a lot. We are giving only symptomatic treatment. And we are seeing that with 5,000 platelet also, we are not worrying at all.
And the patient is also not panicking because you are not worrying.
We are confident. Yes, exactly.
Yeah. Confidence has increased.
Thank you so much. Thank you.
Okay. Thank you. Thank you, Dr. Tushar. Thank you, Dr. Sanjay, Dr. Vibhakar, and also the Enlace Code team, Dr. Rahul and Asif. Thank you, all the viewers. Without you, we will not be here. Thank you for being with us. And Bangaloreans, the good news is, sir is with us on 17th afternoon, 2 o'clock to 3 o'clock. Keep all your questions ready. So after your session, I have told them that they can get all their doubts cleared.
Thank you so much.
So,
see you, Dr. Preeti.
Yes, sir. See you, sir. See you personally on Sunday.
Yeah.
Okay.
Thank you very much. Thank you, Dr. Sanjay. Thank you, everyone.
Thank you.
On behalf of FFPI, I thank all the audience. Thank you very much for joining. Stay tuned for the next.